Okay, so I will take the position that restrictive procedures do have a higher rate of weight regain. And frankly, I don't think there's much to debate about this. I'm just going to share with you what we have in the literature, on this topic. And these are my disclosures. I don't think any of these have any particular conflict with the presentation today. I do want to point out that my new home after 15 years at the Cleveland Clinic is in the state of Louisiana, Baton Rouge, Louisiana, and you can see here that in terms of rates of severe obesity, Louisiana has the highest rate in the nation in terms of severe obesity, and this is the location of our new center. I also want to point out and just recognize all those people suffering in Louisiana and all the Gulf Coast area who are dealing with the recovery from Hurricane Ida. Now, first of all, let me just begin with a couple points I want to make about the terms that we are using today, and I think they may not actually be the most ideal terms. Now, this term recidivism, we're trying to get away from this because it definitely does have some negative connotations and some sort of implied blame on the part of the individual. So we're trying to get rid of that term and actually use the term weight regain, which is just factual. A person, for whatever treatment they're having, whether it's medical or lifestyle intervention or surgery, that they gain some weight after this procedure. And then also, we're trying to steer away from this term restrictive procedures. This is somewhat of an archaic, obsolete term that described operations years ago that primarily dealt with altering gastric anatomy. And I'm not sure, honestly, what the best term for these procedures, but perhaps something more like gastric volume reduction procedures as opposed to restrictive procedures. Now, these are the 4 common operations that we have today, and if we're going to, categorize them into certain anatomic and physiologic sort of pathways in terms of their mechanisms, I think we could probably put the sleeve gastrectomy and the gastric banding into this sort of gastric volume reduction sort of grouping, or for the purposes of this debate, we're going to lump them into the, quote, restrictive procedures. The other operations, the gastric bypass and the middle pancreatic diversion, while they do have a component of gastric volume reduction, also employ some degree of intestinal bypass, which adds a whole nother dimension of mechanisms at play here. Now, let's just get right to the data. Here's a very good study from the Veterans Administration published years ago that are comparing 3 operations head-to-head in patients who are matched for key preoperative demographic factors that likely play a role with weight loss and weight regain. And you can see here gastric banding, sleeve gastrectomy, and gastric bypass. Now, I want to point out that something that you're all familiar with, if I can show the pointer on this mouse. There we go, yeah. Virtually all these weight loss curves, whether it's a lifestyle intervention, medication, or surgery, all have a similar pattern in that you see a nadir weight occur sometime after the initiation of the procedure. In this case, for surgery, usually between 1 and 2 years where we will see a nadir, and then almost always you will see some degree of weight gain. And this is true for all types of procedure. Now, the degree of weight regain may vary somewhat. The slope of that regain may vary from procedure to procedure, and it looks like we might actually see a difference here between the bypass and the sleeve in terms of the slope of the weight regain. But I think it's important for all of us to recognize that virtually every intervention does lead to some weight regain, which suggests that there are certain biologic factors at play here as opposed to just pure behavior. Now, this is a very large study from the PCORNet research group. Large number of institutions throughout North America participate in this with a very large sample, over 46,000 patients. So you can be sure that this data is fairly reliable. And again, you see the same same sort of shape. And of course, this is mean weight loss, which doesn't necessarily reflect the degree of variability in these cases, but in terms of the mean weight loss, you see the nadir between 1 and 1.5 years, and then weight regain. But clearly, at the 5-year mark, you see a clear separation between the banding and the sleeve gastrectomy and the gastric bypass. So this data does suggest that the so-called, and I'll put in quotes again, restrictive procedures have a higher rate of weight regain than the gastric bypass or non-restrictive procedures. Here's another way to look at the same data from this study, and they broke it down into the percentage of patients at 1, 3, and 5 year, according to the intervention, who had achieved at least 5% total weight loss. And here you see a big separation favoring the bypass over the banding procedure, and the sleeve gastrectomy are pretty close, but at 5 years it looks like there's a drop-off more with the sleeve. And then a similar pattern with greater than 10% weight loss, again favoring the gastric bypass over the so-called gastric volume reduction procedures. And then when you go up to 20% and 30%, you see the same pattern. And the longer the follow-up, the greater the weight regain or decrease in weight loss, we can say. And it's such that at 5 years, you tend to see a pretty big gap between the bypass, the sleeve, and the banding procedure, clearly suggesting that there is a big difference. And here's another way to look at it from this table. This is the same data set, comparing the sleeve versus the gastric bypass. Focus on the 5 years here. About 18% total weight loss for the sleeve, about 25% for the bypass, a net difference of about 7%. The band versus the bypass is even bigger difference, 14% weight loss. And then the band versus the sleeve gastrectomy, here you see about a 7% weight loss. So when you look at these three procedures, the sleeve is almost right in the middle between what you get at 5 years for the band versus a gastric bypass. Another set of data from the P-Cornet group looking at patients who had type 2 diabetes. Now, diabetes itself may be a biologic determinant that may lead to a higher rate of weight regain. But here in this study, very large sample, almost 10,000 patients, you can see in terms of weight loss alone, the sleeve gastrectomy has a higher rate of weight regain compared to the gastric bypass. And this study also looked at remission rates showing a favoritism toward the bypass over the sleeve. Now, all that data I just mentioned to you is retrospective observational data. Now, what about prospective randomized controlled trials where we can be more confident that we're dealing with groups that are more identical in terms of their risk factors? So I'll share with you the Stampede study. This was a study I was involved with, a sample of 150. This had patients were randomized to 3 groups: intensive medical therapy versus sleeve gastrectomy and gastric bypass. And here, there was a difference favoring the bypass over the sleeve in terms of weight loss at 5 years. Another study, this one randomized patients to the single anastomosis bypass, the Roux-en-Y, and sleeve gastrectomy. And at 5 years, although the clinical difference seems to be fairly small between the sleeve and the bypass, this difference in terms of excess weight loss was statistically significant, favoring the gastric bypass over the sleeve gastrectomy. And then this study, the SM-BOSS, 225 patients randomized to sleeve versus Roux-en-Y gastric bypass. This one's showing at 5 years a mean 61% excess BMI loss, which is another way to express weight loss, versus 68%. Now in this study, this was not statistically significant. Now I do like this type of graph because it does very nicely show the variability. If you look at any one of these curves, you can see that there are some that follow right along the average, but there are many, these are individual patients who have perhaps excellent weight loss at the beginning, but I mean, look at this one patient, at 5 years, almost down to zero weight loss. So you can see the degree of variability, which I think is what's really most informative for us as clinicians, recognizing and identifying the variability, trying to understand better why some patients respond better than others long term. And here's another study, the sleeve pass, 240 patients randomized to sleeve versus Roux-en-Y. And with the sleeve, you see at 5 years, 49% excess weight loss in the sleeve group versus 57%. And this one was statistically a significant difference favoring the gastric bypass over the sleeve gastrectomy. And another look at the same data from the sleeve pass study, looking at the number of years out at 6 months, 1 year, 3 years, and 5 years, using this sort of forest plot, which is a nice way to show the data. At each of these time points, you see that the gastric bypass, in terms of the weight loss, is favored over the sleeve gastrectomy by a fairly significant margin expressed in percent excess weight loss. Now, in the field of bariatric surgery, we have the luxury of having quite a few studies that have 10-year. You won't see this type of data with medical weight loss, 10-year follow-up. So with gastric bypass, about 18 studies that show excess weight loss varying anywhere from about 50% up to 84% weight loss. We don't have quite as much data for the sleeve gastrectomy. But when you look at the overall average at 10 years, both are pretty darn good, but it does look like the gastric bypass holds out better at this 10-year mark than with the sleeve gastrectomy. And finally, I do want to point out that we have to recognize that it's not just the procedure itself, but there are often many other determinants that affect long-term weight loss. And here's just a list of some of those preoperative factors that might play a role, such as gender, age, ethnicity, socioeconomic background, the starting BMI, the presence of certain comorbidities, particularly diabetes, psychosocial factors, eating behaviors. But the data I showed you clearly shows that there is a procedure-specific factor that allows prediction of long-term weight loss, and there's a whole host of post-operative factors as well. So all these should be kept in mind overall. So the take-home message, I think, the data is pretty clear here. There's really not a whole lot to debate, that the so-called restrictive procedures, I'm talking about gastric banding, sleeve gastrectomy, have a higher rate of weight regain in the long run. But I think more important, we need to better understand the biologic mechanisms that drive weight loss with each of these procedures, and we need to develop better approaches to improve these modifiable risk factors that lead to weight regain in the long run. And finally, I just want to invite everyone to a relatively new virtual conference called PB Grand Rounds that takes place once a month, usually on Thursdays. Our next one will be this Thursday, September 2nd at 1 p.m. Eastern Time. So if you're here in Vegas, it'll be 10 a.m. And Dr. Aaliyah Minion, a colleague, will be talking about how can metabolic surgery save lives in the COVID era. So I hope to see you there. Just go to the website and just log in at 10 o'clock.